Welcome to this webinar of My Sexual Health on endometriosis. I'm Dr. Elna Rudolph, the clinical head of My Sexual Health. March is Endometriosis Awareness Month, and it's a time to shine light on a condition that is affecting millions of women. 190 million women globally live with this condition, and it's often misunderstood and misdiagnosed. Many people suffer from it for years before they get the right care, and that's why we've invited Dr. Viju Thomas tonight. As a leading expert in minimally invasive surgery for endometriosis, he is here to share the latest insight on diagnosis, treatment, and what patients need to know. Dr. Viju Thomas is a leading expert in minimally invasive surgical techniques for gynecological conditions, with a special focus on endometriosis, oncological surgery, and neuropelviology, which he will tell us more about. As the head of the Minimal Access Gynaecological Surgery, or MAGS unit at the University of Stellenbosch, and the president of the South African Society of Gynaecological Endoscopists, Dr. Thomas, thank you for being here. It's such an honor for me to share this stage and space with you tonight. We've had a few minutes to connect before the session, and you already got me so excited because I can see that you are equally as passionate as I am about women's health. And women's health is not only about helping that one person sitting in front of you, it's also about getting the whole system in order. And I can see how your career has been dedicated to that. And it's great for me that you have honored us with your time to be here tonight. Thank you very much for joining us.
Thank you for having me.
Dr. Thomas, I'm going to start with this webinar with just asking you if you can just explain to us what is endometriosis, please?
Yeah, thank you. Endometriosis is the presence of endometriotic tissue, the tissue that is supposed to be within the womb. However, it's not in the womb, it's growing outside the womb, and usually grows in areas mostly in the pelvis and the abdomen. So it's when the tissue that's supposed to grow inside the uterus is growing in areas that is not within the uterus. That's basically what endometriosis is.
Okay. And do we know what the cause is for that? Do we have some kind of idea of why some women develop endometriosis?
I think we can accept that the theory of what we consider retrograde menstruation, which is the sort of like theory everyone shares, is not true. So I think let's start with what's not true so we can move that aside.
It's okay to stand on your head when you do yoga while you menstruate. You're not going to get endometriosis. That's what you're saying. Okay, yeah. Thank you.
So that theory doesn't hold much water.
Okay.
The newer theories are a combination theory because we don't have one single theory explaining it. And these theories include a combination of genetic, immunological, environmental factors, or what we call epigenetic factors that affect how we sort of present, I suppose. Those factors seem to be the main players at the moment when it comes to the development of endometriosis. And I think possibly a combination of all of the factors that I've mentioned is probably what's taking place. But the answer is no, we don't know.
Is there something, I've got 2 daughters, is there something that you think I can do that will make it less likely that my daughters will suffer from endometriosis one day?
No.
No, nothing.
No. I think there is a genetic predisposition, and I think there's an immunological predisposition, and I think it is just one of those things that we at this moment cannot do anything about. To prevent it, if you say, well, I've got a young child and she's going to be a teenager one day, can I prevent endometriosis?
No. Okay. And the whole notion about it's type A personality, highly strung kind of people that have more of a tendency to develop this?
It's an interesting one, and it's difficult to answer without actually putting into context how that data was collected. The data was very old data, and if you look at it, there's a selection bias in who they looked at, and that selection bias is based on who was able to access healthcare.
Okay. Yes. Okay. So as you heard, I've gone completely off script there because I felt it's important to get just some of the basic questions that I often get in my office about endometriosis out of the way. But if we talk about, as you could see here, it's a massive issue for our audience. How do you get the right diagnosis? What are the signs? From your perspective, what advice can you give people first in terms of signs of endometriosis? Let's just start with signs of endometriosis. How can you know whether you might suffer from endometriosis or not?
It's a good question. Firstly, most endometriosis is asymptomatic. So most is asymptomatic.
Sure.
So you could have it and not know. And
okay.
What does that mean? It means that when the symptoms arrive, then you might become symptomatic, and those symptoms are many. So let's just say your symptom is subfertility or infertility. You won't know until you're trying to have a child, but you have endometriosis until that point. But just because you didn't have pain and up to that point or other symptoms doesn't mean you didn't have it. So I think that depending on the symptoms, they'll present at different times. So what we'll find is that you'll have two main categories of patients. Well, let's make them three. Patients of quality of life issues, which revolve around pain, social issues, issues with school, work, relationships, and that sort of thing. Also, and the second group is patients with infertility and only infertility. Then you get the combination of both. Those patients will have both. So it will depend on how what the symptoms are and when they will present. Often the patients with infertility and subfertility will often find help because they're seeking to fall pregnant at a younger age, what we consider to be reproductive ages. So they would go and say, well, I've been trying for 2 years and I can't fall pregnant. And then usually they're with highly skilled specialists who deal with fertility, and they are aware of endometriosis. So the probability of a patient suffering from infertility being diagnosed is higher than a patient with pain being diagnosed. Yeah. So the issue with pain is that it gets confused with numerous other things, like IBS and interstitial cystitis, and very, very often wrongly labeled. But the symptoms overlap very easily. And because of the lack of knowledge and awareness amongst healthcare workers, they get labeled with another condition when they actually have endometriosis. So I think there's a massive overlap in symptoms, which sort of puts a lot of healthcare professionals and leads them into the wrong direction, if that sounds right. Also, I've noticed with our medical students and so on that the curriculum doesn't really cover endometriosis sufficiently. So if we look at the literature of undergraduate students and postgraduate students, it's not sufficient. It's very, very basic. And that is something that I think we're already starting to do. We're starting to change that curriculum at university level so that more and more students, starting from first year upwards, at least those are the people I get exposed to, are getting more and more information at a younger age so that they are able to see in a lot more detail about what the symptoms are, and they're able to pick them up. So what are these symptoms? I think that the main ones that we want to look at are severe menstrual pain. And when we say severe menstrual pain, that's a difficult one to quantify because it's difficult to quantify what is not severe menstrual pain, for some people. So some people, what's the reference to what is my normal pain? It's a difficult one. So it can happen that patients might normalize it and say, well, this must be, that's one of the factors to consider. But again, it doesn't, that severe menstrual pain is something to be aware of, and perhaps as people around, we can also guide people and make people aware what we consider to be severe pain. Chronic pain, now that is pain that persists. For the purpose of discussion, let's call it pain that persists beyond the menstrual period, but also persists for a longer period of time, like six months and onwards. In endo patients, it's a lot longer. But that non-cyclical pain that we get is also a highly concerning symptom for me specifically.
Yes.
That is now moved from early disease to progression of disease.
Okay.
So I think severe menstrual pain is one factor, but that when that starts moving to non-menstrual pain, we start to have, we've got advancement of disease. So that for me is a more advanced symptom. Painful intercourse, very often there are many causes, as you know, and I'm sure this has been discussed before. So I'll only discuss the one that's specific to endometriosis. So usually this is a deep pain during deep penetration. And very often there is an organic cause for it, meaning there's usually growth of endometriosis in what we call the rectovaginal area or the retrocervical area. So actually something there that causes pain every time that area gets irritated or touched or whatever it might be. So deep pain during intercourse is one of the signs to definitely look out for. Painful bowel movements, unexplained infertility, fatigue and bloating, I think also something to keep an eye out for. They're a little bit more general, but definitely something that falls within the spectrum of symptoms.
Okay, interesting. So the fatigue is an interesting symptom for me. You know, sometimes you see a patient with an HB of 8 and you ask them if they're tired and they're like, no, they're not tired. And then but so many people come and sit here on my chair tired. So why does endometriosis cause fatigue?
There are many causes. Off the top of my head, one of the first things that comes to mind is just patients not getting sufficient sleep due to pain.
Okay,
so
yes.
You need rest, and if you're taking 5 bottles of pills and you're still not sleeping, and you're probably not you're going to stay awake. Then the next day, and this happens for over a long period of time, it's going to catch up. That's chronic fatigue. So I think the pain is one factor. The second thing that we need to think about, and this is my own personal theory, it's probably not personal, based on reading also. I think we've got neurological involvement by that time. So what you have at that point is for those who know what I'm saying, there's an overdrive of the sympathetic system. Now that happens when you've got organ involvement in the pelvis. And basically that means, let's just say you've got the rectum or the bladder or whatever it is, you've got a growth, and that's affecting that organ. So it affects that organ in numerous ways. One is with pain symptoms. 2 is with what that organ does. Let's just say, for example, you might leak, you might have blood in your urine or whatever it might be. But the third thing it affects, and we forget this, is that organ is usually innervated. Now, when you have a disease process taking place, very often those nerves can get affected. And if you have sympathetic overdrive, what you can easily see in these patients, if you look carefully, is you'll find that they'll be sweating when they have pain, and they have eye changes, they've got pupillary changes, and they're also just really always tired because this is massive overdrive. So I think those are some factors that lead to fatigue. But also what happens with these patients is now you've got issues with correct diet, which is a big factor which we haven't discussed, and often we can change a lot with the diet and try and make sure that they're eating correctly, because very often a lot of my patients have come to a point where they're just not ready to look after themselves, to eat correctly and to change their bowel habits and to increase the foods that they need to be eating so they actually have energy. The diets are often filled with what's frankly junk food. So I think there is a personal factor involved in this way, a patient modifiable factor, which is diet specifically, which could possibly improve significantly the symptoms of fatigue, sleep, and so on, for numerous reasons.
So do you have a diet that you recommend, like a Mediterranean diet, or is there a specific endo diet that you typically recommend?
It's a difficult one to go and put my name on one particular diet, and I think it's also a dangerous one to do. But I think that there are a few principles. One is try and think about not taking in inflammatory foods. So, it's all well and good to have a cucumber and a stick of carrot stick and think you're eating healthy, but very often it's what you're eating that is bad that's causing you harm. So, and a lot of that food can be inflammatory, so it's worthwhile looking into it. Second one is antioxidants. So we need to have foods that are high in antioxidants because there's a lot of oxygen-free radicals in the inflammatory process that need to be mopped up. And thirdly, of course, is just proper nutrition. Giving your body the nutrition that the cells need at a cellular level to be able to function correctly and to be able to heal itself. Because I often tell my patients that you could probably just eat your medication if we get it right, and minimize the amount of pills we need to pop. And I truly believe that if we eat correctly, we're probably going to change a lot of how this disease can be managed.
Look, I can tell you a doctor's personal story is not science, but I had 10 fertility treatments, multiple surgeries for endometriosis, severe adenomyosis, and I changed my diet significantly after the 10 fertility treatments and then had 3 natural pregnancies. Diet and supplementation, and really I don't want to make it into science, but I can really attest to my body, and what I can really attest to is when you're unhealthy, when you've got that sick organ inside your body, it's very difficult to take care of your body. You're mad at your body for not being healthy enough to carry a pregnancy or to fall pregnant at all. You are so tired of trying. There's so many emotions associated with it, and you feel so out of control that focusing very specifically on eating all of these healthy foods, I found it difficult. Now, later in my life, I've been finding it much easier. But I remember when I was suffering, when I was in the thick of it, it was actually really, really hard for me to do it.
It is. And, there's a big choice when you make that sort of decision. But once that decision is made, it becomes a lifestyle choice, because it's not just it's a lifestyle. The way you live, how you decide to treat your body is a lifestyle. And once you get it right and you start to feel better, which a lot of endo patients do, it's very rare they'll go back. So it's worth the transition.
Yeah, absolutely. It's not a 6-week quick fix diet. It's really changing your whole lifestyle. Can I ask you to just give a brief explanation of what the difference is between endometriosis and adenomyosis, please?
Yes. So endometriosis is, as we mentioned, the disease or the endometrial tissue that is growing outside the uterus. Now, by definition, anything growing outside the uterus is endometriosis. So we take the uterus out of the equation. So we can, for example, say hysterectomy is not a cure for endometriosis because we have no endometriosis in the uterus. So that's important, just as a definition. With adenomyosis, what happens is there's uterine disease also. So you'll have the endometrial tissue that invades into the muscle of the uterus and the womb. And as it invades there, it starts to cause pain, inflammation, and lots of discomfort, causing the similar symptoms to endometriosis. But it's actually quite much more difficult to manage than endometriosis, because a cure is just really not something we have at the moment.
Okay, but the pathophysiology is similar.
It is similar. There are two pathophysiologies. You've got the theory that you could have an inside out or the outside in theory. Inside out means you've got endometrial invasion from the endometrial lining going into the wall of the uterus, as we would expect, we think, through that sort of basal layer. And from the other side, it's coming from the abdominal cavity, where it has been growing as endometriosis and invading from the outside. Both these exist. They also manage differently. But the bottom line is they're very invasive, and they're able to sort of almost invade the uterine wall.
Okay.
The endometrial tissue is not normal endometriosis. So the tissue you'll find in the uterus histologically And if you study genetically, it's not the same as what you find with endometriotic disease. So although we say it's endometrial tissue, it behaves differently.
Okay, interesting. And now we go over to treatment. So firstly, I want to ask you, is there evidence base for something like pycnogenol or some kind of a food supplement that is beneficial for the treatment of endometriosis, scientifically?
A food supplement?
Like pycnogenol or some kind of an anti-inflammatory or antioxidant, a supplement.
I would have to go with no, because I would have to be able to quote the evidence, and I don't have evidence to say that you can do this and it's going to improve, or you can do that. But we can categorize foods into certain categories and say, like anti-inflammatory, antioxidant foods that are high in those are probably very beneficial. But I wouldn't say there's any specific cure. No, not something you can consume.
Okay, so I mean, there's lots of supplements being sold to be great for endometriosis, but you don't think that there's a proper evidence base for that?
I think that not unless the patient is eating correctly. So if the patient modified their diet and they actually have a very good healthy diet with a wide variety of foods, and you still need supplementation, sure. But that's not where I want to start, because
yes, I hear you.
We can possibly say that you have very expensive urine if you're taking that many supplements. So you probably don't need all that. So I would say let's start with what you eat.
Yes. Yeah, and people find it's easier to throw money at the problem and buy expensive supplements than change their lifestyle. Okay, now we are coming to this person has quite significant pain when they menstruate. They are thinking it might be endometriosis. They go to the GP. Of course, the GP is not going to be able to put a camera in there to go and look, is it actually endometriosis? They want to start on a trial of treatment. What would you suggest?
So it depends where you are. We've got a variety of people in our audience who have access to, for example, someone like me who's going to be able to do a laparoscopy but do the treatment while we're at it. So if you're there, then that's easy. On the other side, the difficult one is where we don't have access to people who are going to be able to do that diagnostic laparoscopy. Because if we say that the gold standard, which it still is, strangely enough, although it's not the only way to diagnose it, is still a diagnostic laparoscopy, then the probability that 35 million women in South Africa will get a diagnostic laparoscopy is very, very low. So for that reason, you look at a lot of the guidelines that have come out that suggest that you don't need a diagnostic laparoscopy to make that diagnosis. You can treat, and if the patient's improving, then you can start to make that diagnosis and say, look, we're probably dealing with endo. But then take it to the next step. Then you might have to refer and so on. But definitely, I think if there's a suspicion and the patient is responding to hormonal therapy, and with the suspicion of endometriosis, then you can almost say, let's manage this as endo, and let's take it further.
Okay, so now to break it down, a patient comes to see me or a nurse in a clinic or a GP, and from the history, we think that it might be endo. Is it okay to start that person just on the pill, a normal contraceptive pill? It's accessible at every clinic in South Africa. Is that an okay entry-level treatment for endometriosis?
Yes.
Okay, great. When do you know that you need to do something like Vizan rather than the pill?
So to answer that question, let's add on to the previous answer. So starting that patient on a combined oral contraceptive is not sufficient. It is going to assist the patient with a number of things. One, it will hopefully assist with the symptoms that the patient has. Two, hopefully it will assist with reducing the progression of that condition. But if you as a healthcare professional have thought endometriosis and that's what you're treating, then you should not be changing that medication. The patient should ideally go to a place where there is someone who is able put the right steps in front of the patient to say, look, this is what you need. Remember, every endo patient is different, and the needs of that patient differ at different times. So if the patient is 16 years old, for example, versus 26 or 28, and she desires fertility, and now we start the patient on COCs, such as a combined oral contraceptive, and then what we're basically doing is, yes, we're treating the symptoms and managing the pain, but we're also delaying her fertility, and that might be something she desires, and we might really just be treating something and wasting her time, So I think every patient has to be individualized based on what her needs are at the time of presentation. And if that is the case, what we don't want is the wrong management for the wrong need for the needs that the patient has, just because it's a blanket rule. So I think let's individualize and put that patient to context, because time is important for these patients, for many reasons.
So we have the whole spectrum. I have a 17-year-old who can access your private practice. And this is I did put her on the pill, and the pill did improve her symptoms significantly. How soon should she be seeing a surgeon that can treat her surgically? Does she just stay on the pill until she desires fertility, or does she need the surgery as soon as possible? If you can explain that a little bit, please.
It's debatable, and again, individualized. So there are two thoughts here. The majority of the thinking is that that patient can probably be managed conservatively until such time she's in her early 20s. And if surgery is needed, then we attempt it at that time. And that is the traditional thinking. Because obviously we don't want to cause harm. Because surgery is an intervention. The second new line of thinking that's coming out is they've been looking at the progression of the disease and when that progression takes place and how much of that disease progression takes place. And recently we're starting to see that the progression of the disease is usually from about the time the patient starts a period till about the age of 25, 26. So if you start thinking about that, you start thinking, well, if that is our maximal growth at 26 and we do a proper excision at 20, I'm hypothesizing because we don't actually have guidelines here. That's why we individualize. If I can excise that all the endo by the age of 20 and we manage it and suppress it hormonally, then by the age of 26, that should mean that we are not going to have maximal growth, which would have had. Because even if you are on suppression with Visan or whatever it might be, there is still growth. It's not that there is no growth; it just reduces how quickly it grows. Excision followed by Visan has got a much lower recurrence than just Visan alone. So I think that decision should be individualized. So to answer your question, I would refer the patient to a good endo team, firstly, because that patient is going to need care until the age probably of about 50. So what we want to avoid is misdiagnosis, number one. Missing silent disease, for example. So I said that endometriosis can be something that is quiet, but you suspect it for whatever reason. But it can also, for example, cause the ureters to constrict. And if that is the case, they will completely close up. And those are let's call it the tubes that bring urine from the kidney to the bladder, as you know. And if that happens, then what happens is that there's backward pressure into the kidney, and that kidney dies. The patient will have no symptoms that the kidney is dying. So those are things you don't want to be missing. So what you want to do is close monitoring of what could be happening, where the disease is, especially if you've got parametrial disease on the side and ovarian disease, the risk of that goes up. So patients would probably need regular monitoring and seeing what needs to take place. It's not unusual for a few of my patients to just come with dead kidneys, and then there's no way we can save that kidney. So I think the answer would be, let's get that patient to, if possible, to a center where someone is keenly looking for this, so that the next 30 years of a life or so is not marred with repeated surgeries, poor management protocols and that sort of thing. And just somewhere where she feels supported and feels, all right, you know what, I think I feel comfortable and looked after here. So I would say, if on the other hand, the patient, there is no place to refer, which is there, I mean, we have that problem, then the answer would be to manage as best as possible. And I would say try and avoid surgery, in fact. So if you happen to be in a place where surgery is not part of the skills offered routinely, I would probably say you're better off not having surgery, because surgery could be harmful. And we know that post-surgery, there's a lot of issues with ovarian reserve, with scar tissue, and all those sort of things. So I would prefer that those patients don't actually get surgery. So it's a difficult one to answer, but I would say individualize.
So let me see if I understand you correctly. In a country like South Africa, we're very fortunate. There are centers who specialize in endometriosis in the big cities. There are surgeons who do endosurgery on a daily basis. That's their thing. And you think that a patient with endo is in good, I mean, obviously you get better and worse surgeons, and that does exist. But in general, that's the first choice. Just putting a scope into any abdomen by any surgeon who hardly ever does endosurgery, not recommended.
Yes. In fact, we've got studies to show that especially gynecologists and people who dabble in scope work and who dabble in endometriosis will miss the disease.
Okay.
I've been to numerous theaters where I'm looking at the screen and I can see stage 4 disease, and I speak to the surgeon and they, well, this all looks normal. And these are people who are apparently considered endo specialists and in Cape Town, who have just looked, yeah, that looks fine. I'm like, oh my God, we have a problem here. So, getting people to a point where they are able to know what they don't know is a difficult thing to do, because everyone out there thinks that they've got it. But if you can get them to a point where, well, let's look at it this way, differently, and that's where the education and stuff comes in. Let's look at things differently so that these prominent doctors who are managing this are thinking differently about it. So, I would also say that if your gynecologist is predominantly doing obstetrics, there's a very good chance that that doctor is not capable of doing your endosurgery. So you need high numbers. It's just experience. It's nothing special other than the experience.
And it's not only endo that's like that. There are many other examples where it's like that. The more you do, the better you get at it. That's just the reality.
Yes.
So you were referring to stages there. Could you maybe just run us through the different stages, and are there symptoms that you can expect at these stages, or is it purely histological, the stages? If you can please explain that.
Yeah, so the stages are something we should be careful of using, actually. So there's 1 to 4, and that's based on the American Society for Reproductive Medicine. And this is an old classification system, and mostly it's used by patients and doctors and so on. However, there's a lot of problems with that particular type of classification system, which we won't get into now, but we're moving away from it. It is, however, still useful to communicate to people how extensive the disease is, but it doesn't correlate to the symptoms of the patient. Okay. So very often a patient will say, so what's my stage? And if it's stage 4, then it seems to, they feel, oh my God, that explains my pain. But then if you say it's stage 1 and the pain is as bad as the stage 4, like why is my pain that bad? You can have the same pain. The symptoms don't. So for that reason, that system of classification is not ideal. And it's something that we should probably move away from. But it's useful to say, in some circumstances, especially amongst colleagues, to be able to say, look, this is what I found, it's a stage 4, then you know what you're dealing with and what you can expect. And also for patients to try and explain this. If your doctor says I had stage 4, there's a very good chance the next doctor is going to understand that. Having said that, we are moving away from that to a new classification system we call the #Enzian classification. And that has come out in the last 2 to 3 years or so. And it's the one we tend to use a lot more now. So what we're actually pushing forward for doctors, patients, and all radiologists, doesn't matter who you are, to start using that. Because it seems that is a better system of classification, which we can apply to ultrasound, to MRI, at surgery, and with follow-up. Yes, it has a few issues with it, but it's the issues are much fewer than with the previous classification. In general, 1 to 4, but doesn't correlate with symptoms. New classification is the enzyme classification. The hashtag enzyme classification.
Okay, hashtag. Okay, you with it.
Yeah, no, it's not even my name. They call it hashtag. So there was
Okay.
enzyme, and then they did the upgrade. It's like when you have a new car model. You've got a facelift with a new few lights and stuff.
Oh, okay. So
Or
the hashtag.
2025. So this is the hashtag.
Okay. So can a doctor, today I saw a patient that said that she had a ultrasound by endometriosis specialist. I've known this person since she was a child. I am pretty certain she's got quite severe endometriosis. And she said, no, this person did an ultrasound on her and told her that she definitely doesn't have endometriosis. Is that something that the new classification allows, or because when I was last at medical school, it was like a histological diagnosis?
It's a good question, and ultrasound is operator dependent. And in the right hands, yes. So we are moving.
Can you exclude endometriosis with an ultrasound, or can you diagnose endometriosis with an ultrasound?
You could diagnose endometriosis with an ultrasound.
That I can understand more, because you can see there's free fluid, or you can see a possible chocolate cyst, or you can see the adenomyosis in the endometrial line. I mean, I'm not a gynae or a surgeon, but I can imagine how you can potentially see it. But can you confirm that you don't see it?
You can't rule it out.
Yeah.
So it's wrong to say you don't have endo in that regard. So ultrasound today is what we call the gold standard in imaging, and it's as good as MRI. So in the right hands, we can see the pelvic nerves with the ultrasound. We can see, and you can see everything on the ovary. You can see the rectum. You can see, let's just say, for example, there's rectal involvement. And there's a rectovaginal nodule, and patient might require resection. We are able to see the different layers from the outside layer, which is called the serosa, the muscularis, and the mucosa, and we can just see how deeply infiltrated that is. And that almost immediately gives us a surgical management plan to say, look, we will actually need to remove full thickness here. And that means a segmental or a discoid resection. Or we're well above the muscularis and we can get away with the shaving, which means there's less morbidity post-surgery. So ultrasound is the new kid on the block. And I'm glad you asked that question, because I think in the right hands, it is extremely useful. But in my opinion, the number of people who can do that level of scanning in the country are probably less than 3 to 5 people. It is very operator dependent.
And my 30,000 Rand ultrasound is not going to pick it up.
But the machine doesn't matter. When I was studying medicine, my uncle bought me a stethoscope, and it was very cool. There's Littman all over it. Put in my ears, and I was listening. He said, "It's not the stethoscope. It's what's between the ears." So the ultrasound might be not as important as the operator.
Okay, I hear you. Now, what I like about what you're saying there is, well, let me just first see if I understand correctly. You get this diagnostic laparoscopy, right? So you go in with the camera, okay, you see the endometriosis. But are you saying that with the kind of ultrasound that you can do now, even before that first diagnostic laparoscopy, you might know, I need a colorectal surgeon in here with me. I need a urologist in here with me. Or do you have them there anyway, or how do you do it?
100% yes. So you will know with an ultrasound, you'll know. The only limitation of the ultrasound is you can't see above the rectosigmoid junction, but most disease is underneath there anyway, so it's within the pelvis. It's a small proportion, any 5 to 10%, where you'll find extrapelvic endo, for example, the appendix, the cecum, small bowel, diaphragm, and so on. You won't pick that up, but you can pick up almost everything else. And in the right hands, you can actually almost plan your surgery. In Europe at the moment, ultrasound is the mainstay. They don't even do MRI anymore. So many centers will do their own thing. And that's nice to do, because if you think about it and you think about the diagnosis of endo, I'm the president of the Pan-African Society for Endometriosis. When we looked at what can we do in to try and prevent the delay in diagnosis, especially by healthcare professionals, one of them is ultrasound. So where there's a big drive right now to train people to do ultrasound. So who could do an ultrasound? A GP could do an ultrasound, no problem. I mean, the many GPs who can do ultrasounds, and if you don't need a special ultrasound, if you've got a transvaginal probe and you know what not to miss, you won't be able to tell everything, but you'll be able to say something's wrong. That pattern recognition at ultrasound is what we want to teach. So who has them? The GPs will have them, the radiologists will have them, radiographers will have them, gynaes will have them, obstetricians will have them. It's all over the place. So that's a large army of people who we can now give I'm going to call it inexpensive, because I'm comparing it to MRI and laparoscopy. A relatively inexpensive tool to be able to say, look, this is severe. Like, we've got disease that's infiltrating bladder. Let's deal with this.
Yes. So am I understanding you correctly in saying that is then where you will not just keep that person on the pill or set them up to a vasectomy? That's the person that, like, we've got limited access to surgeons, but this patient really needs to get to a surgeon because there's ultrasonic findings showing bladder or rectal involvement, and we're unlikely to resolve this just with hormonal treatment. Is that the reason? Or can you actually manage some of those that have already invaded that extensively just with hormones?
No. As a general rule, no.
Okay. So it's a sifting tool for someone like me that actually see a lot of endometriosis to know that this person I really need to encourage to go for surgery, and another person who might be reluctant to go for surgery early might be okay on the hormone still, although what you said is that there might be ongoing progression, and if fertility is really an issue for you, the sooner you cut it out, the better. Is that like a general rule for people? Because we do get that question quite often as healthcare providers. You're talking about endometriosis, they Google, they see that it is related to infertility, and they want to know what can they do to preserve their fertility.
Yeah, so in general, what you want to do, there are many messages here. One of the principles to consider here are egg freezing, and to preserve some, let's just say, put something in the bank and say, look, if something goes wrong and whatever, there's something there. And I'm not a fertility specialist. I don't like the field, but more and more fertility specialists are moving towards that, and they're encouraging younger and younger women to do it. I'm not going to go into the debates for and against it. I think asking someone who's really young to freeze their eggs is, in my own personal opinion, incorrect. But certainly at a certain stage, one has to consider that. The second, as the patient grows older, and if they're not in a relationship, which happens in many of our patients, those start to become to consider. Or if they're delaying it for career purpose, whatever it might be, that's worth considering. Number two, if the patient desires fertility and wants to fall pregnant almost immediately, there's no role at all for medical management at all.
Yes.
So in such a patient, surgery could be an option, but it also may not be the right option. So the decision there has to be taken whether we move to assisted reproductive technologies such as IVF and all those sort of things. Let's just say we've got a patient who's 32 years old with 5 previous surgeries, 2 of them involved both ovaries, so our ovarian reserve was already very low. AMH is not looking particularly healthy. That patient is the wrong candidate for surgery because we're just going to cause harm. So there you'd want to see how we can avoid harm and move straight towards assisted reproduction so we can maximize the ovarian tissue that is there, and as opposed to going and cutting it out where then we have nothing to be able to use. So I think with fertility, surgery can be useful, but also could be very harmful. So such a patient should really be in the hands of a fertility specialist, number one, in conjunction with a endometriosis specialist. And that decision needs to be taken because that patient's needs are to take a child home And what we don't want to do is to let's say, fiddle around and cause harm and, be
Sure. Okay, yeah,
unnecessary.
that's a interesting. I mean, I'm glad that that you put that on the table, because I think there is a general narrative, obviously not in the more informed circles, that you need to cut out the endometriosis for fertility purposes, but it might not always be the right answer.
Yeah. No. Yeah. Surgery for fertility needs to be done very carefully.
What is the difference between the surgery that you do, this minimally invasive surgery? Is that the kind of a gold standard for endometriosis surgery, or is it different? And the robotic surgery that you do, is that involved in the treatment for endometriosis? Just tell us a little bit about the surgery that you do, please.
Yes, thank you. So minimally invasive surgery is purely just a technique of operating. It involves avoiding open surgeries where we open the abdomen and we're operating sort of with our bare eyes. What we have the advantage of is we've got a camera which is almost like, let's call it your iPhone, for example. Your iPhone's able to take wonderful pictures, zoom into something that is that far away, all those sort of things. We have extremely good exposure, visualization, when we do laparoscopy, minimally invasive techniques. So if the surgery is being done open, in my opinion, it's just not worth the surgery. I think it should never be done open, because you just will miss a lot. I mean, imagine you've got this big, you've got binoculars on and you can see everything.
Yeah.
Why would you not? And it just makes a lot of sense. Also, and once we go into the retroperitoneal space, we're also able to visualize things such as nerves and ureters, and much more easily. And that means we can spare function. Where previously it was just, that looks like endo, let's cut there because there's no bladder.
And
Yeah.
go crazy. Okay, yes.
So there's a very fine delicacy in the work that we can do with minimally invasive surgery. With robotics, it's even better because the dexterity of the instrument, it's basically just an instrument, a really expensive instrument, but it's an instrument.
Okay.
And in essence, what we get to do is the same story. We get to see very, very well and use very expensive equipment to cut out things that are difficult to cut out. So I find robotic surgery very useful. I'm lucky enough to be the only robotic endometriosis surgeon, possibly in Africa at the moment. And I've got over 100 cases behind me. And the only reason for that is because medical aids are not willing to pay doctors to do that. But it's a really good piece of kit, and surgeons should have access to that.
Amazing.
So,
do you have it in the government setup here at Tygerberg, or is it only in the private setup that you have that robot?
It is there in the government and in the private sector. But in the government sector, we don't have to justify its use to medical aids. So at Tygerberg, for example, I have it and I use it strictly for severe endometriosis and oncology patients, who usually are endometrial cancer patients with high BMIs, because it really helps. In the private sector, it's not being funded by the medical insurers yet. The thing, though, is that the learning curve for laparoscopy is about 10 years. The learning curve for robotics is about 2 years. So if we got more surgeons doing robotics, then although it's more expensive, they're going to make less mistakes for those 8 years.
Yes.
And that's good for patient and that's good for doctor.
Absolutely, yeah. Wonderful. Now I see we've got only 2 minutes left here for this webinar, and the time has gone so quickly. It's been wonderful for me to learn from you. Thank you so much for joining us and sharing this space here with us. I will just maybe say something from my perspective in terms of sexual health, that we have found a lot of massive healing in the process of being with a pelvic function physiotherapist as well. That the scar tissue that develops with the long-standing endometriosis, our patients have really had massive relief from seeing a well-trained pelvic physiotherapist, and the ones on our team are sexual health and pelvic health physiotherapists, so they understand it very well. And what Dr. Thomas was talking about, this upregulation of your sympathetic nervous system, where this fight and flight is activated. The physios are phenomenal at actually down regulating that and teaching you to better cope with the pain. So if you are interested in getting treatment, or if you as a healthcare provider are interested in referring your endo patients to one of these physios, please take a look at the My Sexual Health website in the chat. So please, if you are a patient and you've been struggling with endometriosis, I think the take-home message from tonight is there is help available, and can you please reach out for help so that we can help you to have better well-being, better fertility, better relationships and intimacy. Don't lose hope. There is help out there. So thank you so much for joining us. And as you could hear, I learned so much already tonight from Dr. Viju Thomas. So thank you again to him, and thank you to all of you for joining us.
Thank you for all the work you do. Bye-bye.
Thank you. Bye-bye.